All right, at least I got this out of our system. All right, we left off here. So a quick review: the alimentary canal, and so basically, we look at two things when we study this, both anatomically and physiologically. We look at effectively this long hollow tube that goes through us, and long is the watchword. When you're looking at something conservatively, 8 meters, probably a reasonable amount. I've seen 9 on some things, the better part of 30 feet. And all these accessory organs, we have to talk about their role as well. Hard to read this slide. If you can blow it up and read it, if you wish, it gives you an idea of where things occur. But we're going to look at each of these things individually. So just, anything with small writing, I don't even care for. I like this graphic. It's not one I've seen. Okay, to be understand. I mean, again, it's a much longer than you think. Look at the length. I mean, tongue, mouth, okay, esophagus, down to your stomach, just through your thoracic cavity, stomach here, and then all of a sudden, wow. I mean, this is roughly the start of the diaphragm here. I mean, from here to here, look at this. I mean, so effectively, this tube has twisted, twirled, basically sort of cuddled over itself in a very unique manner. But if we took it and stretched it out, and that's something we used to do when we do like one of the dissections, one of the mammalian, just a fetal pig, etc. And you try to take it, and try to stretch it out, clip it, stretch it out, and just compare the length to, let's say, the length of the spine, and we give you an idea of how long yours would be, measuring your own spine and doing it proportionally. And we're not done yet. We all have a whole bunch of large intestine. So there is a ton. I mean, the better part of 5 feet of large intestine, and all of this small intestine. And the big player here, everybody, that small intestine is where most of it all shakes. That are there. It's unique because of this. Everything is 3. All we do is we talk about 3 layers. We have a lining layer, we have a middle layer, and we have an outer layer. And typically the outer layer is, it's like the heart. We have simple squamous epithelia outside, it's the outer layer, simple squamous inside, and a whole bunch of muscle in the middle, cardiac muscle, odds and ends. That's it. Respiratory tubes, all right, they're throwing in smooth muscle, we got some cartilage. Okay. And you have a different kind of epithelial cell. Okay. This is different. You have 4 layers because, and most importantly, the mucosal layer, rather than just being composed of one kind of epithelial called, and it happens to be simple columnar with goblet cells, there are actually 3 layers within that one layer. There have the actual mucous membrane that is directly there, areas where it folds and increases surface area. You'll see that throughout. What it does, basically, like any lining, absorption, secretion. Again, columnar cells are busy, so they can absorb and they can secrete. Hold that in your minds, because when we get to renal, when we get to the kidney, you're going to see tubular cells, same deal. They're not quite columnar, they're cuboidal cells, but because they're bigger than squamous cells, they can do more. So they can absorb and secrete. We'll look at that. It wasn't me. I didn't do it. It has a specialized layer underneath it. The usual submucosas have blood and lymphatic cells, but it has, what's interesting about that, it supplies this rather, and we'll see it shortly, this rather elaborate mucosal layer. And the interesting thing, it's got its own nerve supply. We have a nerve supply in the submucosa that impacts the mucosal layer. We have a nerve supply here in the external smooth muscles, those consistent layers of circular and then exterior to it, longitudinal, make peristalsis, make this thing called segmentation. It doesn't require any nerve supply. The override of the sympathetic and parasympathetic system. Okay, parasympathetic through the vagus nerve, sympathetic system through any one of a number of sympathetic ganglia. Doesn't need it. All they do is accelerate it or slow it down. It runs itself. We call it the gut brain. Okay, it's got an enteric, enteric means of the gastrointestinal channel or gastrointestinal tube or whatever, or tract, whatever you want to call it. It has its own nerve supply. It doesn't need any help from outside because it runs by stretch receptors, and chemical receptors and pH receptors. That's what it runs. That suffices to give instructions. And I am, some may argue, living proof of that. I have, on not one but two occasions, they have cut the vagus nerve to my stomach, called a vagotomy. Okay, it's actually a vagectomy. When you ectomy something, you take a chunk out. On two occasions, to stop it from producing an excessive amount of acid. It's a fairly standard procedure. So obviously, let's say, looking at me, it doesn't look like I missed a whole lot of meals. You didn't see me last year. Oh, you don't look heavy at all, Dr. Stein. You see, that would have been nice. You outrate my professor. When do we get to rate my students? Be happy you're not in the days of the Roman Empire. So mucosa, okay. Now we really get to look at this very, very closely. The mucosa layer has its own lining cells, simple columnar goblet cells. It has its own underlying layer of connective tissue. It's got a fancy name. It's called the lamina propria, proper layer, if you will. And it has underlying it a layer of smooth muscle that surrounds the lumen, surrounds the hollow, called the muscularis mucosa. You'll see it here. Let me show it to you. I mean, I actually would, this is now, if I didn't put these PowerPoints on, this is the Marie PowerPoint, it probably shows it a tad better. See if we can get to it. Nah, it's an A. Hold on, I get it for you. Don't leave the room. I like the way they diagram it here. There you go. This bad boy. Okay, take a look. So these are the four layers. And this is throughout the system. Okay. Here, the lining cell. So here are the simple columnar cells. These indentations found throughout the stomach, throughout the small intestine. In the stomach, they call them pits, P-I-T-S. And in the small intestine, you're going to learn they call them crypts, C-R-Y-P-T-S. Okay? So they're the cells that do all the business. They're the ones that are so rapidly, every 3 to 6 days, we get a whole new set. Billions of cells daily are being replaced. Billions with a B. Okay? Underneath it, this specialized layer called the lamina propria this is where a lot of immunological cells are. Okay? They have little patches of immunological cells called pyres, capital P-E-Y-E-R apostrophe S patches. They're part of, remember we looked at an immune system, MALT, mucosa-associated lymph tissue. So you can call it MALT, and some people call it GALT for gut-associated lymph or lymphatic tissue. And along with that, and again, it nourishes this very, very vigorous. It's obviously going to need a lot of blood supply, a lot of nerve, and a lot of lymphatic supply. And underneath it, you have another layer of smooth muscle that's very unique, called the muscularis mucosa. In other words, the muscle of the mucosa. So understand, when a particle, it doesn't take much. Remember, these are basically flat, very narrow. When anything goes through them, first of all, they initiate stretch receptors. The stretch receptors induce, based on whether it's acidic or basic, whether on what the osmolar concentration is, how concentrated it is. Generally, materials going through here are triggered by the degree of concentration, how many particles. So it's very hypertonic. If you go back and remember hypertonic, isotonic, and hypotonic. pH is a critical factor. It's governed by pH. The stomach's works in an acid environment. The small intestine works in an alkaline environment. Other than those two areas, it's basically neutral, if you want to think of it that way. And lastly, the stretch receptors. Now, what happens to any muscle when you stretch it? It responds reflexively by contracting. And this is, you understand the existential relationship I have with food. I eat, therefore I am. So as the food enters the stomach or the small intestine, this layer embraces, hugs the food for maximum contact so it can break it down chemically and absorb it. Imagine that. It's like here, coming in, it's like, oh, hello. Ah, pepperoni pizza, I haven't seen you in a while. Thank you. You're obviously not foodies. Oh, you're awful. This place up, I'm telling you, this place over at, they opened a Pizza IQ up in Walmart. Not in Walmart, in the Walmart parking lot of Cranberry. We replaced any one of a number of failed businesses that were there. Oh my God. It's a chain, it's a franchise. The dough for the calzones you could cry over. Literally tears. That good. I'm eating one of those, I'm going like, oh, this is heaven on a plate. Thank you. You just don't have so much food, so little time. So that's what it looks like. And now there's so much going on there. It has its own layer beneath it where the bottom of these pits and crypts are anchored, all sorts of blood vessels and lymphatics, all sorts of nerves. Then you have this layer, the circular layer, and then you have the longitudinal layer, and sometimes you even have extra layers, and it has its own nerve supply. So you don't have to worry about telling your gut, oh, I'm eating something, get busy. Okay, it's all under its own control. Yeah, does fight or flight infect it? Sure. Is it busier when we're in bed? Sure. Why most of us end up going to the bathroom first in the morning, whether we urinate or defecate, basically it's spent all night long being very, very active. Okay, all those things are relevant. So I apologize for taking away, and I'll make sure all that stuff's posted. And it may or may not be, I do not recall. And go back to the other one. Just so you kind of know where I was heading. Because they have different terminology. So the submucosa nourishes, supports it, helps move anything that's absorbed, gets it moving into the lymphatics or the bloodstream. You'll find that lymphatics pick up fatty molecules, heavier materials, okay? Whereas everything else that's easily dissolvable in the bloodstream goes by way of the bloodstream. So, and it's just the way things are. Fats and heavier materials, like more complicated proteins, don't do well. Some of them don't do well in the bloodstream. They have to go in the lymphatics, and that goes up through the lymph nodes. And a lot of times from digestion is where we encounter a lot of, as you would know, bacteria, viruses, toxins, and they get their way to the liver, as you will see, to take care of it. The muscularis, first circular, then longitudinal, from inside to out, so to speak. And then the outer lining is serosa. Serosa is moist. This is all designed for one thing. All of those wonderful looking, you see all the diagrams you see of the bowel, all of these tubes are designed to move over one another effortlessly. They don't stick whatsoever. The arrangement is natural. All those folds of that we call it visceral peritoneum. All of these, peritoneum is usually we typically think of visceral peritoneum like around the heart, the epicardium. This is much more complicated. It's a folded layer of lining cells that contains blood vessels and nerve endings and lymphatics. And basically it's the way that all the nourishment, all the blood supply, all the nerve supply, all the way things are carried in and carried out. Moreover, they are so important that we are very, very careful operating not to cut these unnecessarily. Sometimes you have to, obviously, because they keep it very, very viable. And moreover, after that, they hold it in place. Okay, I will tell you the anecdote. I will tell the next class. I've told it already to my advanced class because we do this part in the anatomy part of the program. As a young resident, some guy gunshot stab wound came in. I'm working emergency room. The emergency room doc had come down. He called another doctor to relieve him because he was going to go. We got to operate this guy right away. And Lou, you're assisting me. I knew what to say. Yes, because you can't wait to operate. And so I'm there. What did I do? Hold retractors. And he said, all we have to do and go in, I think this was multiple stab wounds. He wanted to go in and make sure, repair anything that was there and look for anything that had to be repaired, and hopefully didn't run anything too complicated. And so he's basically, he found a little nick in the liver, a couple of little nicks in the small intestine he repaired, looked around, all that type of stuff. And maybe a half an hour in, and I'm holding the whole time, and he's pointing out to me all this stuff. He goes, okay, Lou, we're going to close. I'm going to run the bowel one more time. I don't know what to say. I just say, okay, holding away. He begins to take. Here comes the bowel. He starts going, and it's coming out, and it's on top. The bowel is sitting on top of the sterile field. He goes, I'm running it to see if I missed any little nicks, if there are any little bubbles. And he says, I run it one way and then I'm going to run it the other way. At that point, you would think he would have to delicately, carefully place it back in the proper orientation. Shoved it in. He must have seen behind my eyes and my glasses go. I'm sure my mouth looked like it was wide open behind the mask. I couldn't believe it. He goes, oh, no. It'll go right back where it's supposed to, Lou. You don't have to put it in there. That's what all the mesentery, that's what they're called, the mesentery. They hold it into place. I was looking for this. Oh, I am so happy. I thought I lost it. I get a charge out of that. Charge out of. We have to explain the pun. Allie would have laughed. So, understand, it's a fascinating piece of equipment, your intestine. Okay. Things that we see consistently. So, the walls of the small intestine showing all 4 layers. Okay, and same in the stomach. Here is the goblet cell. The characteristic thing we see on the goblet cell is this. They're called microvilli. It's about surface area. So here's some of the small intestine. Here's the outer lining. Here's the circular and longitudinal. They for peristalsis. Here's the submucosal layer. And here's this mucosal layer. So even though you can't see it without blowing it up, it has, and I'll go into the anatomy and the folds and things like that. It is filled with millions upon millions of little, they almost look like little nubs. But in reality, if you looked at them with a big magnifying glass, you would find that they have these big fingers. The fingers are called villi. Villi means finger. It's all about surface area. So if you go back and look at that tube, so let's say it's a 25-foot long tube. That's approximately on average about 1 inch or 1.5 inches in diameter. So if you took a tube, like let's say you took a hose like that, a garden hose that was pretty big, and you could slit it and flatten it out, 25 feet with 1.5 inches diameter, maybe it's 2 or 3 inches flat on the floor, 25 feet long. Yet the interior of the surface area that's available for exchange to occur, for digestion and absorption to occur in the small intestine alone would approximately be the size of a tennis court. So in that hose that's going from here, probably not to the door, maybe 2 or 3 inches flat, because of all of these adaptations, you're going to see circular folds. You're going to see these fingers. And each of the fingers is surrounded by more little cells. And they have microvilli. Microvilli are additional fingers. It's all about the surface area. I was in a hospital for my second surgery. I was in big trouble. And it was I hate to say, maybe between the internist and the GI specialist, discussing whether they were going to just put me on intravenous feeding, what they call TPN, total parenteral nutrition. In those days we said feed intravenously. And the GI guy was like in the room, not meanly, not nastily to anybody, put his foot down and said, listen, we've got to, if we can take anything inside the normal way by swallowing it, we're better off doing it. It's the most efficient way to get nutrition in. Even it's a matter of just drinking a couple of boosts 3-4 times a day. He says we always use whatever is available to us in there. If that doesn't work, then we go in the other direction. So, which was a lot in about 2 sentences. So unfortunately, I learned a lot about the system because mine was almost removed in its entirety. And in that case, it would have been likely I would be here since that was 25 years ago. It will be 25 years in December that happened. So just little things about that. Mixing movements, sure. Muscles in small sections contract rhythmically, okay? And effectively, we call this segmentation, or in the stomach, churning. It's moving it over and back, over and back, over and back. That's kind of the way it works. Okay. So you're maximally pounding if you want, and at the same time, making the particles smaller, changing it from something that might have been solid to basically liquid and eventually pasty. And what it is able to do eventually, that really facilitates down the road the absorption. Because you get it in the smallest possible particles and then let enzymes in the small intestine break them down to the smallest molecular particles. Like we don't absorb proteins, we absorb amino acids. We don't absorb complex carbohydrates. We don't even absorb disaccharides. We absorb monosaccharides. That's when we hear about somebody being lactose intolerant. It's because they miss an enzyme to break that lactose down to glucose and galactose, which are monosaccharides that can be absorbed. Because that disaccharide is sitting in your gut, it tends to irritate matters, pulls along fluid, and most people get sick to their stomach, diarrhea, or okay. The other activity, moving them, this segmentation back and forth, peristalsis, ring of contraction progresses from start to finish. So think from your mouth going toward the exit point. Propels fluid particles down the track, very much of a wave-like motion. In the small intestine and the large intestine, you get a greater amount of segmentation to complete the process. Okay. In your stomach, there's a certain amount of segmentation, but it's the whole stomach that's involved. So I don't know if it's really a great term to use. And they're just showing it to you. Here's that back and forth stuff that you're seeing. Digesting material, it can move it a little bit this way, a little bit that way, a little bit this way, a little bit that way. And we're talking about peristalsis, squeeze, push, squeeze, push. Like I said, with the toothpaste this morning, same thing I did. I'm at the bottom, squeeze, push. Don't have a lot of teeth. I don't really know toothpaste. You can tell it's the Friday Club. Minimal participants, and most of them ready to have my week's over, shut the front door. Part A shows the mixing movements. Return to parent slide containing image. You can read that. You can read that. Why am I getting this crap? Did I miss something? Oh. Ooh, same to you, buddy. Okay. So, sympathetic and parasympathetic extensively innervate. Lots of different names. Don't worry about it. Parasympathetic, you already knew this, increases. Sympathetic slows it down. We're going to look at enteroendocrine cells in both the stomach and the small intestine. It's almost auto. When I tell you about nerve supply, the chemical controls, the hormones and controls actually come from when you put something in your stomach. Cells actually in the stomach secrete a chemical called gastrin. Okay, I don't know if they point it here like that. It's anything we call an enteroendocrine cell in the stomach. It's got a fancy name, it's the enteroendocrine. It goes by G cells. And remember, stomach, we talk about gastric. The name of this hormone is gastrin. So when food enters your stomach, it sends a signal. The stretch receptors and other receptors signal the stomach, we have food here, make gastrin. And the gastrin made by the stomach acts on the stomach. We call that an autocrine. AUTCOCRINE. It works right up. It actually works on the cell that produces it, and effectively says make more. And what it does is it makes the stomach busy. it starts to move it, increase segmentation, increase peristalsis, increase the production of hydrochloric acid in the stomach, increase the secretion, as you'll see, of pepsin in the stomach. All these chemicals that facilitate or enable our digestive processes in the stomach. And the same thing is true in the small intestine. Same deal. The two hormones that when food enters the small intestine, what's different? First of all, there's a pH sensor because that's an alkaline environment. Acidity enters there, it's like, whoa, stomach's dumping on us, we better get busy. And it secretes two chemicals, one called CCK, cholecystokinin. Cholecysto means gallbladder. Kinin means makes it squeeze. One of its jobs is to release stored bile, which helps to digest fats from the gallbladder if you have one, because sometimes people get it removed. They're non-essential, or from the liver. And then at the same time, that same cholecystokinin also works in the small intestine and says, I need intestinal juices. I need you to get busy. And it signals the most important gland in the whole works, the pancreas, to get busy making all the things we collectively call digestive juices, water, bicarbonate, and a slew of enzymes. And the other hormone that does the same thing, and maybe even more important, that's made by the small intestine to get it going, is called secretin. It's like the word secret with an IN after it. Secretin. We'll see all of those. So it's a wonderful set of controls. The stomach is an acid environment. Small intestine is an alkaline environment. The rest of them are effectively neutral. So pH controls it, stretch receptors, how concentrated the osmolarity controls it. All of that's part of it. And now we look at it independently. So that gives you sort of the, the poor man's overview, so to speak, of this. And like I said, I'm going to go back and forth because the images, I think, are better there of the stuff I want to cover. I'm not going to get into as much gory detail with the enzymatics to learn all the names that are there. There's a lot of enzymes that are there. And I mean, now you guys are so perplexed with urinary and repro. I don't want to overburden you. You write nasty things on that Rate My Professor, which is fine. It's okay. How do you affect a guy who in a year from now is going to be 75 years old? The answer is you can't. DGAF. Don't give. AFF. Flying. Creative use of the F word. Just wait till you get it. If you're going to nursing or in a medical field, wait till you get in the operating room. Surgeons speak in colloquial English and profanity. Patients asleep. They won't hear. Where's my effing instrument? I need this for this. Watch out for flying instrument. I'm sure they still do it. All of a sudden, there's a hemostat flying your way. Prima donna. Think wide receiver, Perkins on the Steelers, that kind of stuff. Prima donna. The mouth. Okay. Mouth does two things. Obviously, it's mechanical digestion, chewing it, using your tongue to move stuff around, moistening it. Okay. Mechanical breakdown. Saliva plays an important role. Saliva is hypotonic. It pushes moisture in. Yeah, we know speech and sensory. All these other things, the palate, the tongue, muscles in your cheeks, all of these are things that assist in the process. Okay. That's really all you have to know about it. Two kinds of enzymes. We start enzymatic or chemical digestion 2 times here. This is the first place until we get to the small intestine where we start digesting starches. It's called amylase. So we produce what's called salivary amylase. That is produced by the glands. What are the glands that are there? So the salivary glands. Salivary amylase. The only time it's where starch, it's like, put that piece of pizza in, it was super hot, and spit it out, it's already starting to break down. Salivary amylase. Doesn't take long. hot pizza. Food mode. And your tongue starts fat digestion. Proteins are untouched. Well, lingual lipase. It comes from your tongue. Lipase, digesting fats. Salivary amylase, there's 3 salivary glands. Parotid, they're in pairs, right, left. Sublingual, under your tongue. Submandibular, sort of in the opening of the big mandible, in the interior. Parotid gland is serous, it's mostly liquid. Submandibular is serous, mostly liquid. This one is more mucus, it's a little thicker. And they all contain the usual culprits, enzymes, part of your immune system, these secretions, IgA, defensins, various chemicals, lysozyme that helps to break down peptidoglycan, particularly in gram positives, micro, okay, all that good stuff. I love this. It's a good point. I like it at the end of the term that we have to hustle to get things in, because you've got most of you have a lot of background for information for, and if you're here on a Friday, most likely you're listening. Yeah, Allie's blowing me off. Date? Did you have a date or something? Did I miss it? No, okay. Okay, sure. Job interview. Anybody else sitting behind? You'll be happy to know I don't do any of this anatomy. None, 0, zip. I don't do teeth. I don't do hard palates, soft palates. I don't do uvulas. I don't use lingual frenulum or inferior labial frenulum. I don't do them. Thank you. Goodbye. You want to know about teeth? You're going into dentistry. They'll teach you. Don't worry about the cheeks. Yeah, all this. Yeah, it's stratified squamous, non-keratinizing there. We don't make the transition until the end of where the esophagus joins the stomach from stratified squamous, non-keratinizing to simple columnar, because they're shared. And food is somewhat abrasive. So until it gets in the stomach, we don't start breaking it down where we have to rely on those columnar cells and the goblet, and particularly the protective nature of the mucus. Other than that, incoming, and once it leaves effectively the colon, and the feces are about in preparation of a bowel movement, and then it goes back to stratified squamous, non-keratinizing. Thick layers of epithelia are protective in nature. So when stratified, protective. Simple squamous is great. Remember, absorption, secretion, a lot of mucus to protect. And depending on the area, it'll be alkaline mucus in the stomach, because it's such an acidic environment, and it'll be maybe even slightly acidic mucus. And I don't know we'll try to do it in physiology. Mucus plays the same kind of role when we start talking about female reproductive, and a lot of that process when you get into how intercourse and fertilization actually occur are a lot of pH controls. Agents that break down the mucus that's blocking the area, allowing the sperm to pass, and then the mucus forming from other chemicals in the event of fertilization. It's something many of you will cover much more thoroughly in nursing when you do the OBGYN component. So hopefully we'll touch on it. Yeah, my first wife, despite not being able to have children biologically, very good at that. She's mostly peds, but a lot of OBGYN. She did all peds, med-surg, no psych, Lamaze instruction, things like that. Since we're having a family get-together, everybody will have a good time. Here she's doing better, but she was not feeling well. So lips, fine, yeah. Tongue, yeah, it's important. Don't care. Yeah, there's tonsils. Palate, don't care about the tongue. Again, the pharyngeal tonsils, so tonsils and adenoids is typically, like when your tonsils were removed, Brooke, just like my kids, they do tonsils and they also do adenoids, which are the ones on that back wall. So it's very commonly done. That's typically why Not, people. Mine, I was done when I was 5. In my day and age, if you had 2 earaches, they yanked your tonsils out. They didn't really know that lymphatic tissue was immunological and protective. They thought it was really the source continuously of all those problems before there's really enough criteria to look for that. So, I mean, it was the busiest office I've ever been in. You made more. You must have seen 100 people in an evening. It's crazy. Everybody, the same doctor, everybody went to. So here, you've probably seen this before. If you haven't seen it before, first aspect of this area, because we talked about it a little bit in respiratory anatomy, the nasal cavity really isn't part of the deal. It's the same kind of thing. There's the eustachian tube. All that's respiratory related. But again, it's a shared passageway. So you have the pharynx, really, which permits swallowing, the muscular portion of it. You have the nasopharynx and the oropharynx, but really the pharynx is sort of like, think of a funnel that's open in the front. And you have 3 layers of muscles called pharyngeal constrictors. They basically how you swallow. Your tongue plays a role, your muscles here in your anterior part of the throat. We're not going into the mechanics of swallowing. And here's the great divide, so to speak, where the epiglottis will flap down, cover the entry area into the larynx when you're eating and food, and that's why your mom always said, don't talk when you eat. The whole thing, Heimlich maneuvers, all that good stuff, yeah. They say a lot with me because all I do is talk. Not doing it. Don't care, not doing it, not in the least. Don't look at me. Nice smile. Don't care. Don't have no idea how they number them. Don't care. Don't care. Yeah, read that. Fluoride, sealants, yeah. My daughter before the wedding, having all this cosmetic stuff done. She took a header when when she was a little girl, and it affected her teeth. So she wanted to get it all done cosmetically. Remember I told you she went to Columbia? Did I tell you that? Do you remember? Oh, jeez. You're a nutcase, Mal. Here's the saliva. Almost all done here. Moistens food particles, binds them, starts to dissolve it. So, and this is the enzyme. It's because chemical digestion of carbs, that's the amylase. Bicarbonate ions to keep the pH favorable. Remember, it's pH controlled. And a lot of the foods we have are acidic. We do not have alkaline foods are bitter to us. Tomatoes, colas, caffeine, coffee, they all have a certain amount of acidity. We have a palate for acidity. Things we squeeze lemon on something to brighten it up. That's what cooking do. We use citrus all the time. So keeping the pH favorable, here are the glands. Parotid, the largest up here. They're the ones with the amylase. Sublingual is mainly mucus. The submandibular is a combination. And lots of minor glands are there. Serous, the enzyme amylase, splitting starch and glycogen to its components. Remember, starch and glycogen are just long chains of glucose. And mucus cells, okay, bind food particles, lubricate, They summarize this very nicely. Here they're located. Here's submandibular. Here's sublingual, the one with the mucus stuff. The parotids are quite large. They get problems in them. My mom had a tumor when she was probably around 70. I'd say maybe around 72, 73. And I mean, for the world, everybody thought it was cancerous. It turned out not to be. It was there. I remember my sister and I going up to stay with her while she had the procedure done. And, so that was, thankfully it healed very nicely. But you hear part of the discussion when we talk about prostate, we talk about breast, which is in repro, pancreas, which we're going to talk about this. They're called adenocarcinoma. Glandular cancers are by far and away the most common. Nothing's even a close second. Lung cancer is typically adenocarcinoma. I'm just showing you a little bit of what they look like. There's really not a lot to say about the pharynx. Okay, the pharynx, again, the three areas. The esophagus is effectively a tube. You don't, peristalsis starts at skeletal muscle about 2/3 of the way down, is replaced by smooth muscle. Peristalsis starts there. But the transition and the epithelia is very sharp at the stomach. That's what we're going to get to. So that's really all it looks like. You have these different kinds of constrictors, superior, middle, and inferior, and they really guide the swallowing. I don't do the stages whatsoever, but when it gets that last stage, the esophagus is just an expansible tube. That's all it is. It doesn't aid in digestion. It doesn't aid in absorption. Mechanical or chemical digestion is just a passageway, period. And it expands. And they always have these pictures, and I always ignore them. So we'll stop it here at the esophagus and just find, I don't want to give it short shift. I want to show you what it looks like. And we will continue on, and you guys can go complain.